stop sharing and share it again. See if I can share this one. Can you see my presentation, Siddiqa?
काफी clear है, so okay.
Okay, so I'll just see if I can. So I'm
मैम फुल स्क्रीन कर दें इसको.
G. So the learning objectives are that I'll be correlating the pathogenesis with the clinical features of the common red cell disorders, and I'll also be describing the lab diagnosis for these four main types of anemia, which are hypochromic microcytic anemia, megaloblastic anemia, hemolytic anemia, and aplastic anemia. So what I intend to do is I will spend 15 minutes on each type, and then in the end we can take questions and answers. So regarding regulation of erythropoiesis, some points of physiology before we jump on to the red cell disorders, that mainly it is the sensor organs are present in the kidney which secrete erythropoietin. So whenever there's hypoxia, that is reduction in the red cells, the kidney starts producing erythropoietin, which stimulates the bone marrow. The bone marrow requires certain micronutrients like iron, folate, and B12, and this there's an increased production of red cells, which thereby decreases the secretion of erythropoietin. So this is the cycle in which erythropoiesis is normally regulated. In the bone marrow, we have the precursor cell, which is proerythroblast, which goes through three stages of early, intermediate, and late normoblast. And there's in this, the changes that happen are the extrusion of the nuclei. The nucleus becomes smaller. It is finally extruded at this stage. And then we have a reticulocyte, which has some remnants of the RNA, but it is a little larger cell than the normal erythrocyte. So the normal red cell, which is so formed, is devoid of any, I should say, it has no mitochondria, no lysosomes, no endoplasmic reticulum, no Golgi bodies. It's just a membrane which contains hemoglobin and some enzymes which have been formed at this stage. And you can see the change in the color from blue to red. So it is this stage, which is the intermediate normoblast, where the hemoglobin starts formation. This is blue because of the protein synthesis, and now it becomes red at the polychromatic stage or the intermediate stage, where the hemoglobin synthesis is starting, and that's why it is called poly, because it has two colors. You should also know this, that only the erythrocytes are present in the peripheral blood, and in an adult, reticulocytes are present up to the stage of up to the limit of 1%. The remaining cells, which are the early erythroblast and these stages, they are present only in the bone marrow under the normal condition. But in case of anemia, some of these nucleated red cells may come out because of their stress erythropoiesis, and you can see nucleated red blood cell as a sign of bone marrow responding to this stage of anemia. And this also means that reticulocyte, which is present in the peripheral blood, is a very good cell that tells you about what is happening in the bone marrow. So if there's marrow failure, then reticulocyte count will decrease. But if there's increased erythropoiesis because of hemolysis or any other reason, the reticulocytes count will increase. So this serves as a window for as a marker for what is happening in the bone marrow. And you usually don't do bone marrow examination in case of anemia, and we make our diagnosis based on the reticulocyte counts which are present in the peripheral blood. So with this, I can come to the definition of anemia. Anemia is defined as either the decrease in hemoglobin or hematocrit or red cell count below the reference range for age, gender, and geographical distribution. And what does that mean? That means, according to the age, for example, the neonates have a very high hemoglobin of 19, for example, and if the hemoglobin is 13, they will be considered as anemic. But if the same if it is an adult patient with a hemoglobin of 13 gram, he will not be considered as anemic because that falls in the reference range for that particular age. And then there's a difference between reference range for the males and females. The males have a higher hemoglobin compared to the females, and they have a lower reference range. And geographical distribution, for example, residents of Quetta, for example, they have a higher hemoglobin, and they will be called as anemic if the hemoglobin falls below the reference range for that particular area. How does the body compensate for anemia? The body tries to compensate it by increasing the cardiac overload, so the patient suffers from tachycardia. There's redistribution of the blood, which means blood goes to the vital organs. The skin and the peripheral areas like limbs, they are devoid of the blood, therefore their skin appears pale. And low affinity of hemoglobin for the oxygen. So the hemoglobin releases more oxygen to the tissues because because of the shift in the oxygen dissociation curve to the right side, and there's more delivery of oxygen to the tissues. So this is how the body tries to compensate for anemia, and this goes on for some time. But if the anemia is persistent and goes on for a long time, then the patient suffers from there's a problem, and the patient gets suffer from cardiac failure, and the patients may have various serious problems related to anemia if it is not treated timely. So, there are various ways of classifying anemia. And why do we need to do that? Because we need to know how to diagnose the patient. So, we have various ways of classifying anemia so that we can diagnose the patient. Until unless we diagnose the patient, we cannot treat him. One of the way which is very easier for me and for other clinicians to diagnose, to classify anemia is based on mean corpuscular volume, MCV. MCV stands for mean corpuscular volume, which means the average red cell diameter, the volume of the red cell, and normally it ranges between 80 to 100. So anything which is MCV below 80, the red cells will become microcytic, and those microcytic cells are usually hypochromic as well. They are hungry for iron, or they have less hemoglobin in them due to various reasons. And the classical examples are the iron deficiency anemia, thalassemia, anemia of chronic diseases, and sideroblastic anemia. I'll do these two in a little more detail because these are the ones which are common and you should know more about these. Then among the normocytic anemias, we have various anemias. I will do more in detail the aplastic anemia and hemolytic anemia because these are common and you should know more about these. Then we have macrocytic anemia where the red cell MCV is more than 100 femtoliter. They are large cells. That's why it's called megaloblastic anemia. The classical example is vitamin B12 and folate deficiency. And then, sorry, this is not iron, this is folate deficiency. And then myelodysplastic syndrome and alcohol intake hypothyroidism are other examples where patient can suffer from macrocytic anemia. So we will take first hypochromic microcytic anemia, which is the commonest anemia not only in Pakistan but globally. So I'll present a case here that this is a 25-year-old primary gravida. She presented with pallor, loss of appetite, and breathlessness on exertion. Her hemoglobin is 7 gram per deciliter, which means she is anemic. RBC count is 2.8, which means it is low. MCV and MCH are 70 and 20, which are again low. This means this patient is suffering from hypochromic microcytic. Yes, so this patient is suffering from hypochromic microcytic anemia. So the commonest example of that is iron deficiency anemia. If this is the condition of the patient and the presentation, I will first go hunting for iron deficiency anemia before I think of rare diseases like sideroblastic anemia or thalassemia, which is common in Pakistan but rarer than iron deficiency anemia. So little about the physiology because that will help you in understanding the iron deficiency and anemia as well. you know that iron is taken in the food. The best sources of food in the iron are usually the meat. Vegetables also contain iron, but they are not in the biological form which can be absorbed readily. And what happens is that iron is the main site of absorption of iron is duodenum. Usually about 1 milligram of iron is absorbed per day, and this is taken up by the transferrin. Transferrin acts as a transporter protein for the iron, and this transferrin actually takes iron to every cell of the body. But those cells where those parts of the body or those organs of the body where the maximum iron requirement is, that is the bone marrow. And why? Because hemoglobin is the form in which iron is present. Majority of the iron, functional iron, is present in the form of hemoglobin. The rest are in the form of enzymes or in the form of storage iron. But that's why the 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 most consumption of the iron is for the by the bone marrow for the formation of red cells. And these red cells, then they are after some time, like 120 days or so, they will be destroyed in the spleen or in the liver, where the red cell membrane is removed. There they will be hemoglobin will be reutilized, the iron will be reutilized, and that will be taken again by the transferrin, and that will be again taken to the bone marrow. So one point which you should remember here is the most important source of iron for the red cells is not the food iron. It's mainly the iron that is released by the liver and the spleen, which is the redistribution of iron, because when the red cells die, they release the iron, which is then taken up again by for the formation of the new red cells. One of the hormone that is synthesized by the liver is hepcidin, and you should know this, that it is a negative regulator of iron absorption. So in case of iron deficiency anemia, the synthesis of hepcidin decreases, and that helps in the absorption of iron. But if it's a chronic inflammatory disorder, for example, infection, inflammation, for example, rheumatoid arthritis, for example, cancer, their cytokines like IL-6 and lipopolysaccharide, they help the liver, they ask the liver to secrete more hepcidin, and that inhibits the absorption of iron. So you should know that the iron absorption is very finely regulated in the body. It is not, it is absorbed according to the requirement of the body. So in case of iron deficiency, iron absorption is increased, but in case of infection and inflammation, iron absorption declines. And what is happening at the level of tissue? I told you that iron is present in the form of heme iron, and the other is non-heme iron. The heme iron, which is present in the meat, is absorbed. It is absorbed via this directly. It is absorbed, while the non-heme iron, the ferric iron, which is present in the food, it is in the oxidized form. It needs to be reduced before it can cross the membrane. So what you need to remember is whenever the iron is passing through the membrane, it needs to be in the reduced form, that is the ferrous form, and which is Fe2 plus. And this is done by the duodenal cytochrome B, which helps in the reduction of the iron. And this iron is transported through a dimethyl transporter 1, which is DMT1 protein, that helps in the transport of the iron, which means iron which is taken in the meat or in the vegetable both go in the form of iron, either directly or through DMT1. And then the body decides whether this iron needs to be taken to the blood, or it will stay in the for example, it will stay in this in this cell, and that will be shed off later. So what happens here is, according to the need, for example, if there is iron deficiency, again this will be transported, this will be reduced, this will be transported through ferroportin, which is present on the basal surface. This is again a transporter protein that facilitates the transportation of iron molecule to the ferroportin. And then this iron, which is in the reduced form, it needs to be oxidized again, and which is done by the hepcidin. And this ferric form, in the ferric form, it will be taken by the transporter protein, which is transferrin. So you can understand that there's a very fine regulation of the absorption. It is this here that will, the genes here which are present here along with that hepcidin, which is HFE gene, that decides whether the iron will be transported to the through circulated to the blood and will be taken to the erythroid marrow, or it will stay in the mucosal cell. And this mucosal cell, obviously they have a life cycle. It will not stay in the intestine forever. It will be shut off. So that means the absorption of the iron is regulated at the level of duodenum. It will be transported if it is needed. If it is not needed, it will be shut off and it will go into the stool like that. So with this, what happens when the patient is suffering from iron deficiency anemia? Why that happens? The most important cause, which is worldwide, is this, which is inadequate intake. People who are vegetarian, who are malnourished, they are the ones who suffer from this, because yeah, their diet is devoid of the meat which requires iron. But then there are other causes as well. For example, they are like maybe reduced absorption through the because of the problem of the stomach. Why? Because this as you know, secretes various enzymes that are required for the absorption of iron. The iron that is absorbed, I told you, is in the reduced form. So it is the acidic medium of the stomach that helps in that reduction. So any problem in the stomach will also lead to iron deficiency. For example, the patients on PPIs, on the antihistamines, H. pylori infection, and so on. The other problem is hookworm infestation. Hookworm infestation, or Ankylostomma duodenal, that is very common in Punjab areas, especially of Pakistan, where the people walk barefoot in the fields. This stay in the stomach, in the intestine, and cause slow blood loss, and the person finally suffers from iron deficiency, because this parasite is taking iron, or is feeding on the intestine for the blood. Then there may be increased demands. For example, the infants pregnant in the pregnancy, they have a very high demand for iron. So this they may they are this is a particular group that prone to become iron deficient. Then there may be chronic blood loss. For example, patients who have GI cancers. Heavy menstrual bleeding is another thing. Patients on NSAIDs and aspirin, they also suffer from iron deficiency anemia when they stayed on that for a prolonged period of time. And one thing which I told you before, that iron is present in the storage form, which is present in the liver and other organs, and then there's functional iron, which is in the form of hemoglobin and various enzymes. So when there is a deficiency of iron, it is the storage pool that goes down first, followed by the functional pool. So that means patient's serum ferritin may be low, but the hemoglobin may stay good for a while before it is starting dropping off. So the early iron deficiency you can pick up by the low storage pool, that is you measure in the laboratory through serum ferritin. But later you can see that MCV, MCH, they start declining, and then the hemoglobin finally also drops. So this is how the iron deficiency progresses, and it keeps on progressing until unless it is treated. So what are the clinical features of this iron deficiency? The patient, they are not very typical for iron deficiency anemia. That they happen in all the kinds of anemias, and patients suffer from apathy, fatigue, difficulty in focusing, breathless on exertion, because the oxygen saturation declines, and for activities which require higher oxygen demand, for example, climbing the stairs, the patient feels breathless on that. There may be hair loss, pale conjunctiva, there may be glossitis, nails may be brittle. Why these things are happening? Because iron is required not only for hemoglobin synthesis, but it is also required for the enzymes, and it is also required for various functions that may be happening in the epithelial cells. So that's why the nails become brittle, the hair loss happens, the glossitis happens. So iron is required not only for the hemoglobin synthesis, but it is also required almost by every cell of the body for doing their epithelial function. It takes a while before it gets into. I am unable to move my slides. So regarding lab diagnosis, we do lab diagnosis for anemia. We do it in 3 stages. We want to know whether there's anemia or not, and then we need to know what is the type of anemia. And in the second step, we want to know what is the reason for anemia. That is, we do the biochemical assay, and then we want to know what is the underlying pathology that can help in the specific test. For example, in case of iron deficiency anemia, the hemoglobin will be low, and since the red cells are hypochromic and microcytic, you can see here, the cells are smaller, the central pallor is increased, so MCV, MCH are low, RBC count becomes low, and red cell distribution width, which is a measure of anisocytosis of red cells, that is also increased, which means some of the cells are very small, some are larger, because they are at various stages of formation of red cells, and they represent various degree of anemia which is progressing on over a period of time. So the red cell becomes smaller and smaller as the iron deficiency advances, therefore the RDW increases. So this CBC tells us that yes, the patient is anemic, and yes, the patient is having hypochromic microcytic anemia, and with this peripheral blood film typically looks like that of iron deficiency anemia. So the next thing we do is we check for the iron profile, and typically in these patients they have low serum iron. Total iron binding capacity is increased because less of it is bound with the iron. The iron saturation declines, serum ferritin declines, and this tells you that this patient is suffering from iron deficiency anemia. Then we need to know why this patient is deficient for iron. So the history tells us a lot. For example, the nutritional history tells you the patient is not taking their food, or the patient is having heavy menstrual bleeding, or the patient is pregnant, patient is infant. That gives you an idea that what is the cause of iron deficiency anemia. Usually you need to do a stool GR and a stool focal blood to see that patient is not having some parasites, or the patient is not losing blood through stool. And this is very common for patients who are taking aspirin, that they are losing blood in their stool. So this is something which you need to do when you suspect iron deficiency in the patient. So there are some of the questions which I have for you, which I hope that you have gotten from my presentation for iron deficiency anemia. That the hormone that inhibits the absorption of iron from duodenum is yes. Good. The trans So what I'm going to do, instead of taking answers from you, I'll just leave the questions to you. The transported protein that helps in the absorption of iron from intestinal cells is DMT1. The commonest cause of iron deficiency is nutritional. Intestinal parasites that can cause iron deficiency anemia is Ankylostomia duodenum. Yes, and hepcidin secretion is increase or decrease in pregnancy?
Decreased.
Yes, very good. It is decrease in pregnancy because it's a state of iron deficiency, right? It's a negative regulator for iron absorption. So good. With this, we come to the second topic, which is thalassemia. You need to know the various types of sources of hemoglobin. Initially, it starts in the yolk sac, then goes to the liver, spleen. Finally, at the 3 months of gestational age, it's the bone marrow that takes over, and the spleen and liver slowly stops synthesis of hemoglobin. Initially, the hemoglobin that is synthesized, it is the eta chains which are synthesized, and it's mainly the gamma chains that are synthesized, which belongs to hemoglobin F. At the age of 3 months, the synthesis of the beta globin chain also starts. So that means hemoglobin A synthesis starts here at the age of 3 months. And the three different types of hemoglobin are A, F, A2. What's the difference? The difference is in the non-alpha genes. All of them have two alpha genes, but the non-alpha genes are different. They are beta in hemoglobin A, gamma in hemoglobin F, and delta in hemoglobin A2. And this is the structure of the hemoglobin A. It is a quaternary complex. It has four chains of globin chains, which two of them are alpha, two are beta, and each one of them has a heme group. Therefore, that means one molecule can carry four oxygen molecules. Each one of them have their own heme group, which is situated in the crevice or in the pocket of the chain. What are the types of thalassemia? Because there are two chains, alpha and beta. You can guess there are two types, alpha and beta. For alpha, the chromosome is 16, and for beta, it is 11. You should remember these chromosome chains. They're usually asked in MCQs. The genetic error in the alpha is deletion, but for the beta, it's mainly mutations. And what happens? This is the beta chain. On the right side, you can see, you know that we have exons and introns. Exons are usually the portions of the DNA which helps in the transcription, whereas the non introns are the ones which are the non-coding sequence. If the patient has problem at the splicing junction, for example, at the junction of alpha and beta, usually they don't get that severe. Uh, if they have this in the intron, which is the non-coding sequence, they usually have mild anemia, which is beta plus thalassemia. But if they have if they have frame shift or stop codons in the exon regions, which you can see here, that will lead to beta not thalassemia. Beta not means either there is no production of hemoglobin A or the beta chains, or very little is produced. So beta not is the severe form, whereas beta plus will result in the milder anemia. And here you can see that I've written that the various genotype and phenotype and the clinical features. And this is all you need to understand here, that in a normal person, there are two beta chains which are normal. So they are represented by beta slash beta. Mainly hemoglobin A synthesized, which is the majority of the hemoglobin, which is 97%. A2 and F represent very small percentages of the total hemoglobin, and obviously there are no clinical features. But when we say the patient is a carrier or trait for beta thalassemia, that means one of the gene is effective. That is, he is a heterozygote. Either he has beta naught or beta plus, but in the heterozygote form. And because he has one normal beta gene, therefore he can there will be synthesis of hemoglobin A, but the synthesis of hemoglobin A2 and F will be increased, and that's how we diagnose beta thalassemia trait, because of the greater synthesis of hemoglobin A2 and F. Clinical features are usually none here. Then there's another one, which is beta thalassemia intermedia, where these patients are heterozygote. They may have beta plus with beta naught or beta plus homozygous for beta plus. They usually have hemoglobin F, but they have moderate anemia because some of the hemoglobin A is also synthesized. So they may require transfusion, but not that much. Then we have beta thalassemia major, which is actually beta naught, beta naught. Is that the patient is homozygous for beta naught, and all they are synthesizing is hemoglobin F, and they have severe anemia. They are actually transfusion dependent anemia. And how does it? What happens in thalassemia major? If we start from here, the problem is in the synthesis of beta chains. So what remains is alpha chains in the red cells. These alpha chains are very insoluble. They aggregate. They result in the formation of red cells, which are hypochromic microcytic. Because they are not up to the mark, they have membrane defects. They have defects in the hemoglobin. They will be destroyed in the spleen. Then some of them will be destroyed in the bone marrow itself, and the net result is the patient is anemic. There's tissue hypoxia. Obviously, erythropoietin secretion is increased. The patient tends to end up in a blood transfusion. That itself has a problem because the patient becomes iron overload. Cardiac cirrhosis happens, hepatic cirrhosis happens, and there's also the another problem is there is increased iron absorption because of the anemia. They tend to be increased iron absorption, and therefore there is again iron overload. The same effects happen. One very bad effect of anemia is there is extramedullary erythropoiesis, because the spleen and the liver are the organs which know how to produce red cells, because they have done that in the fetal life. So they start producing red cells, so they become enlarged. Spleen grows up, liver becomes enlarged, and there is hepatomegaly, splenomegaly in these patients. If they are not treated, if they are not transfused, then their organs start enlarging. One of the um, cause of death in these patients, the commonest cause of death in these patients is cardiac failure because of the iron overload. And then because the bone is trying to produce more and more red cells, therefore the skull, which has the capacity to expand, the maxillary bone that expand, they start becoming very thin, and therefore there's a characteristic heron end appearance on the skull. But that happens only when the patient is not treated and remains anemic for a prolonged period of time. I also want to give you a brief picture of alpha thalassemia, because alpha and beta thalassemia have the same kind of laboratory features and diagnosis, but it is less common in Pakistan. It is more seen in African countries or in, I should say, Southeast Asia. And not that common in alpha thalassemia. Normally, there are 4 alpha genes which are situated on chromosome 16. The red one indicates the absence of the gene, and I told you that alpha thalassemia happens because of the gene deletion. So if one gene is missing, it will become alpha thalassemia, silent alpha thalassemia. Usually there are no abnormalities. And if 2 genes are missing, they become a carrier. It may be from different chromosome, or it may be on the same chromosome. And then hemoglobin H disease, where 3 hemoglobin alpha genes are missing. This is the one hemoglobin H disease which present just like thalassemia major. They are severely anemic. And if there are 4 alpha gene deletions, it will not be compatible with life, because you know that every hemoglobin requires alpha gene. So if alpha genes are not synthesized, the fetus cannot grow, because each hemoglobin starting from the embryonic life requires alpha genes. So this is incompatible with life, and they usually die. How do you diagnose? Obviously, it's the same picture which you see. There's hypochromic microcytic anemia, RDW is increased, RBC count goes down. This is a this is a typical picture of the peripheral blood film. Nucleated red cells are present. The target cells are present. The presence of nucleated red cell tells you that bone marrow is trying to produce more and more red cells, and but is in a state of stress erythropoiesis. The nucleated red blood cells are usually not seen in case of iron deficiency anemia. So this indicates that there is hemolysis going on, and there's more nucleated red blood cells which are there. And how do you diagnose it? For beta thalassemia, you do hemoglobin electrophoresis or hemoglobin chromatography, and you find that majority of hemoglobin which is there is hemoglobin F, and that's how you diagnose. If this is a patient of beta thalassemia major, the hemoglobin will be all F. There will be hemoglobin A will be 0, and A2 will be variable. That tells you that this patient is suffering from thalassemia major. For the patients who may have been transfused, you may not be able to do HB electrophoresis because of the transfusion. The donor red cells are also present in the patient. So for that, you need to diagnose the patient on PCR, and you find the in the uh, the mutations which are typical for beta thalassemia. They can be identified through PCR. So again, now we come to the questions. The questions are: hemoglobin A consists of 2 alpha and 2 beta chains. Hemoglobin F shifts the oxygen dissociation curve to the left. Thalassemia major has predominantly hemoglobin F. Thalassemia minor has no symptoms. Deletion of one alpha chain will result in silent carrier. Hemoglobin electrophoresis is required for the diagnosis of beta thalassemia. There is percent chance of having a baby with thal major if both parents are carriers of the abnormal gene. So, because it's an autosomal recessive disease, there's a 25% chance of having a baby with thal major. This may be a question in your exam as well. It's very commonly asked. And 4 beta chains will result in hemoglobin H, and 4 gamma chains, if they aggregate, they form hemoglobin parts. This is also one of the common questions that is asked in exam, and you should remember this, that 4 beta chains will produce hemoglobin H, and 4 gamma chains will produce hemoglobin parts. Now with this, we come to the third portion of our lecture, which is normochromic normocytic anemia, and we will discuss hemolytic anemia here. You know that red cells are destroyed within 120 days, but in case of hemolytic anemia, this process may be reduced to 5 days or 10 days, and more red cells may be destroyed. So normally what happens after 120 days, the red cell is destroyed within, this is the macrophage, which is in this, I should use this. This is a macrophage where this is happening. It's mainly the hemoglobin produces heme and globin. The globin is taken up to the amino acid pool, and heme is the part which we are interested in, which releases its iron. But it also releases its biliverdin, and biliverdin is converted to bilirubin, which is in the unconjugated form is transported to the liver where it is conjugated, and this conjugated liver bilirubin is excreted in the small intestine and then into the feces and urine. I should remove this as well. Every while it gets stuck, I don't know why. So hemolytic anemia can be inherited, which means the anemia is present right from the time of birth, or it may be acquired during the lifetime. In the inherited one, the defects may be because I told you the red cell is a bag of membrane with with the enzymes and hemoglobin, and therefore the inherited defects are related to either to the membrane. They become round, which is in hereditary spherocytosis, or elliptical as in elliptocytosis. There may be enzyme defects, and the commonest is G6PD deficiency. Then there may be a problem.
Please mute कर लें please. बहुत distortion हो रही है.
there may be a problem in the hemoglobin where the sickle cell disease or thalassemia may be there. The hemolytic anemia may also be acquired where this immune mediated related to autoantibody formation, antibody formation which may be formed against one's own red cells, which is autoimmune hemolytic anemia, or they may be formed against other red cells, for example hemolytic disease of the newborn, where the patient, for example patient who is D negative produces NTD against D positive fetus, and these across the placenta and it starts hemolyzing the red cells of the baby, resulting in hemolytic disease of the newborn. Or it may be hemolytic transfusion reaction, for example the blood group A red cells given to the patient of blood group B that results in immediate hemolysis and the destruction of these cells, which is again an also immune mediated reaction. But they may be non-immune mediated as well, which may be because of infections, trauma, drugs, spleen. All these can also lead to the destruction of the red cells. And the commonest which we see here is the malaria, which happens because of the malaria, and the one which happens because of the spleen, that is a large spleen removing the red cells causing extravascular hemolysis. So these are the common type of hemolytic anemias. So the signs and symptoms of anemia, you can understand the signs and symptoms are the same as that of the anemia. The patient has all the features of anemia, but besides that, because there's increased production of the bilirubin, these patients suffers from jaundice as well. And those patients who have intravascular hemolysis, there's release of the hemoglobin in the urine, and the patients have dark red color urine, which tells you that the patient is having intravascular hemolysis. And because the red cells are destroyed in the spleen, the patients have a larger spleen, which is splenomegaly. So I'm not going to discuss, because of the shortage of time, I'm not going to discuss each and every hemolytic anemia in detail, but this is a brief overview of hemolytic anemia. And usually the anemia is normochromic normocytic. Few questions for you. Hemolysis will show an increase in reticulocyte count. Patients will have a rise in unconjugated bilirubin. Patients will present with anemia, jaundice, and splenomegaly. Most common enzymopathy is G6PD deficiency. Most common hemoglobinopathy in Pakistan is beta thalassemia major. Hemoglobinuria means hemolysis in vessels, that is intravascular hemolysis. And DASH is the commonest membrane defect, which is hereditary spherocytosis, not only in Pakistan, but the worldwide, where the red cells become spherical. With this, we come to another type of aplastic anemia, normochromic normocytic anemia, which is aplastic anemia. And here I want to tell you that in an infant, the marrow is entire red, that is all the marrow is involved in the production of red cells or erythropoiesis. But as the patient age, it starts converting into yellow marrow, and in the adult, almost all of it is yellow except for upper end of femur and upper end of humerus, where the erythropoiesis is still going on. So on the right, you can see how the bone marrow aspirate looks like. And in the down picture, you can see how the trephine looks like. You can see hematopoietic areas and these white bubbles, which you can see here. These are actually the fat cells which are present. So normally, the fat cells constitute 50% of this, and the remaining are the hematopoietic cells, which can be seen in the middle. So causes of aplastic anemia, it may be, I should tell you that the most common cause of aplastic anemia is idiopathic. That is, in 2/3 of the cases, we don't know why it happens. But in the rest, it can be drugs or chemicals, radiations, insecticides, viral infections that also cause aplastic anemia. It may be hereditary as well, which is regarded as Fanconi's anemia. child is born with Fanconi's anemia, and since it is an inherited disorder, then that means a number of family members may be suffering from Fanconi anemia. And why this happens? This happens because there is some change in the hematopoietic cell, which is this one. This hematopoietic cells have some of the antigens which are changed, because of which the T cells becomes activated, and they stimulate this T cell expansion, and they release tumor necrosis factor alpha and gamma interferon that destroys the hemopoietic stem cell. Mainly it is the myeloid stem cell that is destroyed. That means lymphoid cells and plasma cells are formed, but it is this one which is the myeloid stem cell declines. This myeloid stem cell is responsible for the production of not only the myeloid cells, but it also is responsible for the production of platelets and red cells. Therefore, everything goes down here. And you can understand if this, what will happen to the patient, that there will be a reduction in all kind of cells. The patient will become anemic, neutropenic, thrombocytopenic. And because of these, the anemia symptoms are the same, which can happen in any kind of anemia. But for neutropenia, the patient may suffers from fever, sepsis, and various infections. And because of the low platelet, the patient may have mucocutaneous bleeding. For example, in this, you can see the lower limb has petechial hemorrhages, which is telling you that the patient is suffering from low platelet count. Uh, uh, like all other anemias, we will do CBC first. There will be, everything will goes down, and because of the normochromic normocytic anemia, the MCV, MCH are usually normal. RBC count, retic count, TLC, platelet, everything goes down, and you can see on the peripheral blood that neutrophils are not there, platelets you can't see. So this is how peripheral blood film looks like. No nucleated red blood cell, which means there's bone marrow failure. And when you do bone marrow examination, you find that all of them is fatty. For example, in this one, you can see that the marrow is replaced by fat cells, and erythropoiesis, myelopoiesis, megakaryocytes, everything goes down. So this is how aplastic anemia is diagnosed. Usually you require bone marrow examination for this. Finally, I come to the last portion of my presentation, which is macrocytic anemia, and in that I will be discussing megaloblastic anemia. In megaloblastic anemia, you know that B12 is, which is taken in the food in the form of meat, that it is bound with the proteins. It is taken up, and in the stomach, it is the pepsin, or the secreted by the stomach, removes the protein part, and this B12 binds with the R binder, which is secreted by the salivary gland. It goes further down, and in the duodenum, this again gets splitted by the pancreatic juices, and this now binds with the intrinsic factor, which is secreted by the stomach. And this combination of intrinsic factor and B12, that is absorbed by the terminal ileum, and then it is taken into the blood and circulated through the transcobalamin, which is the transporter protein. For the folic acid is present in the green leafy vegetables. It is present in the meat as well. It is in the form of polyglutamates. It is reduced to monoglutamate. It is taken up by the intestinal cells, and it is converted to methyl tetrahydrofolate in the form in which it is there in the intestinal cells, and it is transported in this form in the circulation as well. I want to I want to spend a couple of minutes over here, because this is important concepts which you need to understand, that how vitamin B12 and folic acid, they are linked to each other. The methyl tetrahydrofolate, which is here, it is taken inside the cell, and it is reduced to tetrahydrofolate form, which means the methyl group is removed. This methyl group is taken up by the vitamin B12, and it converts. Vitamin B12 is the coenzyme which helps in the conversion of homocysteine to methionine. Methionine is the methyl containing amino acid. So this means if vitamin B12 is not there, folic acid will be trapped in the form of methyl tetrahydrofolate. It will not be functional, and the homocysteine will increase, because if vitamin B12 is not there, homocysteine will tend to go in, will become high. This tetrahydrofolate is converted to methylene tetrahydrofolate, which is actually the functional form that is required for the DNA synthesis. So this is the DNA which is happening here. The DNA synthesis required thymidylate, and this is what is happening here. So you can understand that how B12 and folic acid are required for the DNA synthesis, and if B12 and folic acid are low, the DNA synthesis, which is related to the division of the cell, that will be affected, and therefore the person will suffer from a problem with the division of the cells. This means the cells will be unable to divide, and this happens in each and every cell of the body. But the cells which are rapidly multiplying, for example, bone marrow, that is where you see most of the problem. So vitamin B12 deficiency happens because of the lack of the food, malnutrition, malabsorption, increased requirement as in pregnancy. The commonest cause of malabsorption is pernicious anemia, where the intrinsic factor are not produced because of autoimmune infection. The other, you can also see the various causes of malabsorption because they are related to the absorption of vitamin B12. Folic acid similarly can happen because of malnutrition, malabsorption, impaired metabolism, or increased demand that can lead to folic acid deficiency. And what happens to the patient? The patient is pale, the patient has glossitis because the cell division is not happening, and that becomes prominent in the regions which are rapidly multiplying. For example, tongue, epithelium, the patient suffers from glossitis. And then there's this one problem which is typically associated with vitamin B12 deficiency. There is subacute combined degeneration of the spinal cord, because of which there's loss of vibration, spasticity, there's ataxia because of these damage in the various tracts that are damaged in the spinal cord. And why this happens? Because B12 helps in the metabolism of free fatty acids. If it is not converting methylmalonyl CoA to succinyl CoA, propionyl CoA will accumulate in the body. This is the one, and this will replace the various acids in the neuronal membrane, and that will lead to the damage of the tracts in the spinal cord, leading to neuropathies that can happen in the patient. So for the megaloblastic anemia, again, hemoglobin will be low, but here MCV and MCH will be high. So this is how the red cells look like. They're large cells. They are hypersegmented because of the nuclear division is disrupted. Therefore, the neutrophil will be having more than 5 lobes. The bone marrow will be hyperactive, and you can see giant bands will be present, which again indicates lack of nuclear division that is happening. They become very large. That's why the name is megaloblast, because the erythroblast looks very large in size because they're not dividing. And then you need to do the biochemical assays. B12, folate, they will be high. LDH and bilirubin will also be high because the patient has mild degree of hemolysis as well because of ineffective erythropoiesis. And the various analytes that are related to metabolism of vitamin B12, they also be increased, like homocysteine will increase, and methylmalonic acid will be increased in case of B12 only. You need to have further tests. For example, for pernicious anemia, you need to check for intrinsic factor antibodies. If you are suspecting intestinal problem, one needs to do endoscopy and biopsy to diagnose the intestinal problem, that why the patient is having malabsorption. So with this, I come to the my last slide, which is approach to a patient with anemia. Systematic approach is required. You need to take the clinical details for the patient. You need to find out the symptoms of anemia, which are usually the same. Jaundice and splenomegaly are important in case of hemolytic anemia. Drug history is very important because it can lead to all kind of anemias. History of blood transfusion is important because it tells you that the patient has significant anemia and the patient is receiving blood products. Fever, bleeding, a family history, they are important because fever and bleeding tells you that the patient may be having aplastic anemia. Family history is important because it tells you that the patient has inherited kind of anemia. The first test you do is CBC, and you look at MCV to classify the anemia into the three various types. The second test which you do is reticulocyte count, that differentiates between whether the patient is having marrow failure or hemolysis. Then you need further specific tests to diagnose anemia. And one thing I want to tell you here, which I want to emphasize, that bone marrow examination is usually not needed for diagnosing anemia unless there are two conditions in which it is required. One is aplastic anemia and the other is megaloblastic anemia. Otherwise, usually we don't consider um, doing bone marrow examination for diagnosing anemia. So with this, I come to my last slide, and I did it very timely. Um, it's almost time is up. So because there's no time for the question and answers, but you can, if you have any question related to my presentation, you can email me at bushra.moise@atu.edu, and I'll be more than happy to